Hi, everyone, and welcome to today's webinar, hosted by the American Academy of Pediatrics. Today we'll be talking about concussions. Concussions 101, what parents need to know. We're very glad that you've joined us today. A few pieces of housekeeping before we begin. The audio for today's event will come through your computer speakers, so be sure that they are turned on and your volume is turned up. And we will have time at the end for a question and answer session. To ask a question, just use the chat feature, which is either a speech bubble or a little person icon on your screen, and you can send in your questions at any time. I would now like to introduce our host. Dr. Mark Halstead is team physician to Washington University, Francis Howell, and Timberland High School, and consults with several other local high schools for concussion care. He serves as a medical consultant to the St. Louis Blues, and was a team physician for 11 seasons for the St. Louis Rams. He was an elected member to the American Academy of Pediatrics Council on Sports Medicine and Fitness, and served as the lead author of 2 AAP clinical reports, one on sport-related concussions in children and adolescents, and one on returning to learning after a concussion. Dr. Karen McAvoy is a clinical and school psychologist. She is the author of REAP, a community-based concussion management approach. REAP stands for Remove, Reduce, Educate, Adjust, Accommodate, and PACE. She is also the co-founder and owner of GetSchooledOnConcussions.com, which is a website and training curriculum empowering educators to direct return-to-learn efforts for students with concussion at school. Dr. McAvoy currently provides assessment, treatment, and consultation to adults and children suffering the effects of mild, moderate, and severe brain injuries at the Aisha Brain Clinic in Fort Collins, Colorado. Welcome, Dr. Halstead and Dr. McAvoy.
Thank you, and Dr. McAvoy and I are very excited to be able to present to all of you attending the webinar today about concussions. And so we're going to kind of lay the framework a little bit here as far as what we're going to do. So this is kind of just a summary as far as things that we're going to talk about and cover over the next half hour or so. And so we're not going to go into significant detail about each of these individual things right now, but we'll talk about these as we come across them. So I think the important part for everyone is to be clear as far as what exactly is a concussion. So it is an injury to the brain. So on the spectrum of brain injuries, it is fortunately the mildest on that spectrum, but still nonetheless an injury to the brain. One misconception of concussions is that it's sometimes been described as swelling or bleeding or bruising on the brain, and that's absolutely not the case. It's really more of a functional disturbance in how the brain works. And so I kind of liken it to like a computer that has a virus that just isn't working at full capacity, and that's kind of what happens with your brain after a concussion, and we just need to account for that. So some big important parts is that we don't really also call things as a mild concussion. We say that all concussions, they are injuries to the brain. You get mild or severe symptoms with a concussion, but it still has been an injury to the brain. So when we talk about concussions, we want to talk about things related to sports and how exactly they are affected in different sports that kids participate in. So this is a graph that talks or kind of demonstrates the frequency of concussions in sports. These are various studies that have looked at sports-related concussions, and as we can see, certainly on the slides here, that football has the highest rate, but there are some sports that are close to that and rival that. That would be ice hockey. Wrestling has actually been shown recently to have a much higher rate than previously thought of concussions, and I think some of that is a little bit of the culture of the sport compared to football. There's been a lot of attention played to football recently with regards to concussions. And so wrestling has still been kind of something that's not talked about as much. And so now that people have done a little bit more research, we are seeing that wrestling does have a higher rate. Same thing also with lacrosse and soccer. If we switch to female sports, soccer is the #1 sport for having a concussion, although we certainly see a spectrum of other sports that also produce concussions as well. Interestingly enough, some recent studies on female soccer rates of concussions get close to rivaling actually male football. So again, we see a lot of studies that have them at a lower rate, but there have been some recent studies that suggest that it is much higher than previously anticipated. And certainly I see that in my clinic as well. So this particular slide here, this is actually showing concussions as a percentage of total injuries that occur in those sports. And so I would just pay attention to the top ones here. So the sports that most likely, out of all injuries that you're going to get, you're the most likely to get a concussion in that sport from are ice hockey, boys and girls lacrosse, and cheerleading. And that sometimes surprises people a little bit. But again, I certainly see that as being a team position at high school and being on the sidelines. And I certainly take care of quite a few cheerleaders who have had falls at their Friday night football games, often as frequently as we see the football players that we're caring about that they're cheering for. So again, just something to keep in mind. The other thing to remember here, too, when we look at this slide, we're topping out at about 22% for the highest, which was ice hockey. So, again, there's sometimes a misperception that the only injury you can get from some of these contact or collision sports is a concussion, but that's absolutely not the case. So the vast majority of other injuries we see are things that are not related to sports concussions. So what are common signs and symptoms of a concussion? And there's a whole spectrum of these. And these can be very challenging for a parent or a coach or sometimes even the athlete to recognize. And part of the reason why that is these are things that most of the problems are things that the athlete experiences and a lot of things that you can't outwardly see. So as an example, a headache. We can't see a headache from the outside. We may get clues that they had a hit and they may start holding their head or they kind of shake their head back and forth, like we kind of describe it as shaking the cobwebs out. And so those are some things that may give you a clue, but again, you can't see the headache. We can't see sickness to someone's stomach or nausea, but we certainly can see the end result of that, which is throwing up or vomiting. You may or may not be able to tell if they're having troubles with their balance. Oftentimes we'll see athletes when they get up, you can seem a little bit unsteady or uncoordinated, and that can be certainly a clue after a hit that they may have something. The visual problems, those are definitely things that we don't typically see outwardly because the athlete experiences those. That could be double vision or blurry vision as examples. I've had athletes tell me that when they get hit, they see all one color, like everything goes purple or orange or white, instead of actually having distinct colors for different objects. They can feel very fatigued. They may start to have troubles with light or noise sensitivity. They may feel what they describe as being foggy or just like everything's not all clear to them. They may have a lot of troubles with focusing or concentrating, and they may be slow to answer questions or repeat questions a lot. And then some of the things that we see on the bottom of this slide, so the emotional symptoms and the sleep symptoms, those are things that will develop later on. So as an example, so irritability, sadness, nervous, more emotional, you may see some of those things that occur right away. So an athlete who's normally a very happy person becomes very sad and starts crying after their injury, or maybe the quiet athlete all of a sudden becomes very boisterous after their injury. Those are some clues sometimes. But the sleep disturbances, those are obviously things that we're going to see later on. So the common symptoms that we see, so headache is the most common symptom that we see following a sports-related concussion, but it does not mean that everybody will get a headache. As you see on the slide here, that does not approach at the actual true 100% mark. So not everybody is necessarily going to experience a headache, but it is the most common thing that we see, followed by dizziness, difficulty concentrating, feeling confused, those various visual changes that we discussed, amnesia, and that can be things that happen before the concussion, or amnesia, the things that happen in the immediate period afterwards. And that can be very frightening to parents, especially with amnesia of not being able to remember things that happened after their injury. I kind of describe it as the brain just didn't hit the save button, going back to another computer analogy like the virus from before. And the athlete won't get that particular memory back unless someone shows them a video of what happened or someone describes to them what happened, but they won't have that primary memory because of the fact that they had that amnesia event. And then LOC is loss of consciousness. So that's actually very infrequent after a concussion. So getting knocked out is the other way of describing that. So less than 10%, and some will say it's actually closer to 5% of concussions result in a loss of consciousness. So when do we usually need to have kids go to the emergency room after their concussion or suspected concussion? So these are some general guidelines, and the reason why we suggest people going to the emergency department for these things is we get more concerned about things that aren't a concussion. So as an example, a prolonged loss of consciousness, the big question mark is how long of being loss of consciousness or being knocked out is necessary. So generally for us in the medical world, we describe typically 30 seconds or longer of having loss of consciousness as something to get more concerned about. But obviously no one is sitting on the sidelines or at an event with a stopwatch waiting for someone to go down and starts the stopwatch immediately when they see someone lose consciousness. So that can be sometimes more of a subjective thing than truly objective of knowing exactly how long. But certainly if someone's had been loss of consciousness for a longer period of time, that is a little bit more of a concern. If they have a progressively worsening headache, so it just keeps getting worse and worse and worse, that's always a very big concern. Or if they're describing their headache as being the worst headache of their life, also, again, another concern. If they seem to be becoming more and more difficult to arouse, so they just don't seem to be staying very alert and they seem like they're constantly wanting to lose part of their consciousness, that would be a concern. If they've had a seizure. Now, interestingly, with seizures are very scary events when they happen. But fortunately for us, we know from research that even though that someone may have a seizure, that does not indicate that something more serious has happened. But it is sometimes a frightening event. And so if that's happened for the first time, we do definitely suggest that they get seen in the emergency department. If they have lost feeling in their arms or legs, or if they've had repeated episodes where they're throwing up. And I kind of describe this to parents. I give everybody the 2-puke rule. So if they've thrown up more than twice, I think it's time to get seen in the ER. And these are concerns now that there's something more structural going on. So something like bleeding in the brain is an example that may require a CT scan. Now, that does not mean that if someone goes to the emergency department and they have these things, that immediately a CT scan is going to be done, or a CAT scan as we describe it. But that may be something that they're going to get observed in the ER for a while. And if these things continue to be a problem, or if they resolve, that person may just be observed and sent home, or they may need that further testing. And so, but the big thing we want to stress is not everybody needs a CAT scan. We cannot see concussions on a CAT scan. We can only see the more significant injuries. Unfortunately, those don't happen that often in sports-related injuries. So I want to talk a little bit about the concept of brain rest, because if any of you have had experiences with people who have had concussions in your family, you may have been told that we need to initiate brain rest after a concussion. So what we're doing here is we want to reduce physical activity that increases their heart rate or blood pressure. So that may be not participating in their gym or recess activities, certainly not participating in their sports, doing other exercise or working out, or even thinking about some things like recreational activities that may not be something that you think about intuitively, like skateboarding as an example. And those restrictions are going to change based on the improvement of that person's symptoms. One of the things that we've learned from recent research about concussions, the old approach to not have someone do any physical activity at all following their concussion is something that we try and avoid now. And so we actually start resuming lighter physical activity, something that we call sub-symptom exercise. And what that means, sub meaning below, symptoms obviously are the things that they're experiencing. And so we'll typically recommend things like as brisk walking, and I kind of describe to them like a late for class pace of walking, or doing some very light work on an exercise bike for up to 20 or 30 minutes. And we can do that on a daily basis. What we're trying to do there, though, is keep, again, getting their heart rate up a little bit, but keeping their exercise light, and then stopping if they start to have any worsening of any of their symptoms that they're experiencing. So if they had a headache pre-existing, going into the exercise, and as the headache, if it starts to worsen, say 6 or 7 minutes into the exercise, we'll stop for that day, and then we'll try again the next day, trying to get a goal to 20 to 30 minutes. And the reason why we do this approach now is the research has shown that actually some light physical activity earlier on in the recovery is actually beneficial and can get a quicker recovery than not doing any physical activity at all. This does not mean they're doing their normal sports workouts or sports practices. This is just some very light physical exertion that we're talking about here. And then, which Dr. McAvoy is going to explain a little bit more as far as schoolwork, we do want to reduce what we call cognitive stress. So that's just the overall level of stress of mental activity. So that may be things such as reducing school load or their homework. We may provide for tests to be untimed. We may have to do adjustments to their environment at school. So if they're in a very noisy class or lunchroom and they have sensitivity to noise, we may have to have them be in a different area. If they're in a distracting area, or say that lights coming in through the window and they have a lot of sensitivity to light, and that's bothering them where they sit, we may change their seating in their classroom. We may need to do things like limit video games or texting or reading, but honestly, all of those things have never been shown to worsen a concussion. I kind of like in texting, it's not a very stressful activity on our brain. And so we don't want to take everything away from kids. And so I do let them use those devices. One thing we do discourage, though, is using those devices in a dark room, because that oftentimes, if they have sensitivity to light, irritates them. Another nice thing that a lot of electronic devices have now is a night mode, which actually makes the screens go to more of a warm color, so more of the yellowish color of light that we're used to before the LED lights came across and became more of a blue light. And oftentimes that warmer kind of light actually helps people not be as sensitive to the light. So again, something to think about, how we can still let them use electronic devices without irritating their eyes more. We do want to consider restrictions on driving for those that are of driving age, and we know this from several studies that reaction time can be an issue after a concussion, and so certainly we don't want to put someone at risk for a car accident, especially in someone who is a newer driver. And I stress again, we shouldn't treat concussions like a punishment. This can be a very difficult injury for an athlete to go through, because they're told that, you've had a concussion, you cannot participate in your sport. And we don't necessarily have a specific time frame that we know for sure that you're going to get better. It's different than breaking a bone, as an example, where we can usually give someone a very defined period of time that they're going to take to get better. And so it can be very nebulous. And then when we start doing things like taking other things away from them, that can be very upsetting and anxiety-provoking for a teenager, as an example. And then the final thing I want to touch briefly on is returning to play. So when we talk about getting someone back to sports, it's not they feel back to their normal selves and we immediately let them go back to their normal activity. So what's a commonly accepted practice is this is oftentimes referred to as the concussion protocol, is a 5-step return to play progression. So each of these steps would take 1 day to do. So on the first day, when they're feeling back to their normal self, both in and out of school, we'll let them start some light aerobic exercise, and that may be a little bit more intense than the walking or the biking that we talked about earlier. We'll then progress them the following day, if they tolerate that without an increase in symptoms, to more sports-specific exercises. And then following that, if they're doing well, we would progress them to non-contact training drills. And then we would the day after that, allow them to go back to a full practice. And we put contact practice in there, but obviously not all sports involve contact. And so just a full practice would be more appropriate there. And then if they've completed all that, then they would be considered clear to return to full gameplay. And individual schools may have different procedures that they have as far as following this particular protocol. There may be other steps that a school may do to ultimately determine that that person is ready to go back to play. So that may be, again, individually based, but this is typically the common accepted 5-day sports protocol return to play progression. And we can use this also similarly when we're returning kids back to normal activities like PE class or other recreational sports or activities. So I'm going to turn things over now to Dr. McAvoy.
Great. Thank you, Dr. Halstead. All right, so I'm going to continue on about how to then help our students get back into school. The good news from all of what you've heard earlier is that for the most part, a concussion is a very treatable condition, has a very favorable outcome. 70% of students between the ages of 5 and 18 will recover fully from a concussion within 28 days. That's what the research is showing us. So some of our students will end up getting better within a week or two. Some may take about 4 to 5 weeks. So, but somewhere in that range of about a month's time is the typical time frame of when we see recovery for students, children and adolescents. And there are many factors that will contribute, which will support recovery, and some of these things that will take away from recovery. It could be anywhere from genetics or personality style, learning style, and certainly the support that they get at home and at school will all determine how well they come through that recovery. So 2 to 4 weeks is not a really long time to be dealing with this condition. However, it seems like a very long time for our students, for kids and for adolescents. It's a long time to be out of their sport and away from their friends. And so, and we don't want them to be feeling terrible during that time. So one of the ways that we have found that helps our students and parents and teachers understand a concussion is to remember that it is not a bleed and it is not a bruise, but it is an inefficiency of the cells in the brain. And that then helps our students to think of a concussion as an energy crisis. The cells are getting better over time, but they take some time to heal. And during the time that they are repairing or getting better, the student is much like an iPhone 4 instead of an iPhone 10. They are holding a charge, but not through the whole day. Where they are a car with a small gas tank, where they can get out and get around to do some important errands, but they're going to need to fill more often, and they're going to need to be able to pace that energy. So teaching students and parents and teachers to think of this as an energy crisis really helps to keep the symptoms at bay. The symptoms begin to spike whenever the brain or the cells run on empty. And so helping the student to feel more comfortable is all about helping them learn to manage their energy and keep their symptoms at bay and at a smaller level. So returning to school is the concept of actually getting your child back into their physical seat at school. And Dr. Halstead talked about return to play for athletes. When we talk about return to school and return to learn, we're talking about all of our students. All of our athletes will return to school, but some of our students also do not get their concussion in a sports-related mechanism. They get their concussion by falling or sometimes in a fight. And so when I talk about return to school and return to learn, we're talking about all of our students now, not just our athletes. So return to school is the process that you can help your child learn how to manage their energy so that they can manage their symptoms throughout the day. So start with small little bits of light mental activity at home, like reading or a little bit on the computer, interacting with the family, and then begin to increase that slowly with time, as Dr. Halstead said, making sure that symptoms get to a certain level but don't go over. So using the concept of symptom management is a way to know when and how to increase those activities at home. Here are a couple of mental fatigue strategies that we use in schools, and we would ask that you maybe begin to practice this with your student while they're home and resting for the first few days of a concussion. Pacing is the concept that you would allow your student to take a 5 or 10 minute eye or brain or water break after they've had some time of doing some mental activity. So if you want to have your child do some reading or use their computer for maybe 15 minutes, maybe then they take a 5 or 10 minute eye break or brain break just to reset their energy. And that helps them learn the concept of managing energy and keeping their symptoms at a reasonable level. Or they can take a 20-minute proactive rest break where they know that mid-morning or mid-afternoon they want to take a little bit of rest just to get their charging back up again so that they can make it through the afternoon without a lot of symptoms flaring. So if you can start to help your child to learn these strategies at home, when they go back to school, their symptoms hopefully will be annoying and not debilitating, but we know that they may potentially have symptoms up to about 28 days. So they will likely go back to school with some symptoms. We just don't want them to be so uncomfortable for them that they're not able to really manage at school. We would suggest that your child learning to pace their energy and keeping symptoms at bay throughout the day is going to be a better strategy than letting symptoms build up through the day and then taking a nap later in the day. If your child needs to take 10 or 20 little rest breaks of 5 minutes at a time through the morning and into the afternoon, that would be a good way to manage those symptoms and to promote recovery. That would be better than allowing them to take a nap later in the day. Napping later in the day will offset sleeping at night, and being able to sleep through the night is very restorative and helpful for recovery from a concussion. So we would suggest trying to get them used to the idea of resting even for 5 or 10 minutes of closing your eyes or taking a little bit of meditation throughout the day rather than napping too late in the day. Return to learn is the concept for teachers to help your child be a student in the classroom. When the student comes back to school, we want the teacher to be working with them on pacing their energy and keeping their symptoms at bay as much as possible so that they're able to be comfortable enough to listen and learn through the process of the entire day, if at all possible. There are many reasons and many ways that a teacher can support a child in the classroom who has medical or psychological or social issues, and a concussion would just be one of those temporary conditions that a teacher can support right in the beginning of the first few days of them coming back to school. I put a note in here that what we're seeing in the clinic is that a lot of doctors are holding students out of school for the entire time that they are symptomatic, which we know now can be up to a month's time. There's not a really good medical reason for that. We find that, in fact, holding kids out of school for too long will make them quite anxious because they're missing a lot of instruction. And the American Academy of Pediatrics clinical report on returning to school, which was written by Dr. Halstead, suggests that a student should go back to school when symptoms are tolerable, intermittent, and amenable to rest. We find that to be generally days, maybe the first week of school they might miss, but generally students are not out of school for the entire time that they are symptomatic, which means that they return to school with some symptoms there, and having our teachers help to pace that energy and help to pace those symptoms is great for them being able to hear instruction, which is important for then the teachers being able to make any academic adjustments. Once a student has been in the classroom and can hear the lesson, then the teacher has the option to try to customize the classwork and the homework. And some of the things we would encourage teachers to consider would be a removal of non-essential in-class work and homework and a reduction of semi-essential work. We want the student and the teacher to be working closely together on only what is a reasonable amount of essential work, because a concussion will impact how quickly or efficiently a student will learn. And so if they're learning at a slower rate and they just need more time to complete their work, they're not going to get through everything. So therefore, cutting down some of that work would be very helpful. Many of our teachers like to give the academic intervention of a postponement of work or extension of work. That can be helpful for some things, but it's not a great strategy if a lot of work is piling up. So a removal of work and a reduction of work would be very helpful for our students. And of course, what do teachers really worry about is, did this student learn the material that I needed for them to learn over this period of time? Did they learn that lesson, and can they show me that they've learned that material? Can I test them on it, and how do I give them a grade? So the other thing that we suggest or encourage to our teachers is to really consider exempting some testing in the beginning of the concussion, maybe with the first 1 or 2 weeks, and then slowly begin to add back in testing with time, and to be creative with how you assess measurement of learning. Perhaps give students the option for open books or a collage, various things that will help them show that they have learned the material without having to do the exact same amount of work. This is because a concussion tends to impact memory. And short-term memory, which is the ability to learn new material, is really what school is all about. And so for a short period of time, while the student is still recovering from a concussion, they're just not going to be able to show that they are learning quite at the speed and retain as much information as they would otherwise. And then finally, if you are the parent of a student who is struggling with symptoms from a concussion beyond the typical framework of 4 weeks, we would suggest that you talk to your pediatrician or your doctor about that, because there are many new types of therapy that can really help a student come through some of the eye and ear issues and balance issues that we know are related to a concussion. And if you are a parent who sees that your child is struggling at school for a longer period of time, we would suggest that you talk to the school nurse or the counselor or the school mental health professional or a principal for direction at school. Know that schools will and can support students for longer periods of time from many reasons. And a concussion is one of those medical reasons that we can support for a longer period of time, and there's a process for that already built into schools. So we would suggest that you talk to your school about that. All right. I'm going to stop there so we have some time for question and answer. So I am going to give this back to the host to direct the questions. Thank you.
Great. Thank you so much, Dr. Halstead and Dr. McAvoy, for all that great information. And we do have some time right now to answer some questions. So if you have not already done so, please use the chat window to send your questions. It's great if you can use the all panelists option in the chat box. That way our presenters can see those very easily. But also be aware that Dr. Halstead and Dr. McAvoy will try to respond to all the questions in the orders that they arrive. However, they may not be able to answer every question. And so while they are looking over the questions, we are going to, I'd like to remind you that if you have not already done so, to please register on healthychildren.org. That way you can receive not only our e-newsletters, but you get a personalized homepage and you start to receive information early about special offers and other webinars such as the one that we are doing today. I'd also like to remind you to please follow us on social media. You can find us on Facebook, Instagram, Twitter, and Pinterest. So please follow us and share our information. And I'm going to see now if our presenters are ready to answer any questions.
Absolutely. So, here's a question as far as how much time in minutes or hours in total per day is permitted in a day with electronic use. And so I try and avoid putting like absolute concrete numbers on those types of things because that'll vary from person to person. We may have a child with a concussion who does perfectly fine and has no issues with electronics at all. And that can be certainly, well, happen. We'll see it a lot in our office. And then there are some people who really struggle with that. And one thing I try and stress is that I try and make the emphasis that electronics are not all bad. We can actually use electronics for some kids in concussions to actually help assist their recovery from concussion. And so that may be doing things like audiobooks as an example. If someone has a lot of troubles with reading, we may actually use them in different forms of as far as education for them. And so some kids do tolerate things very well with larger print font, which I can do very easily on an electronic device. So there are some things that definitely we can do to help out with those types of things with electronics. So there's not a specific hour or day, as Dr. McAvoy was mentioning. It's going to be individualized as far as how much is too much. And that's, again, just listening to the symptoms that that person is experiencing. I do see a lot of questions on here, though, about younger children. So this was not really intended to address younger children as far as concussions that happen in kids that are a year or two. Those can be obviously a lot more challenging injuries because a lot of them can't communicate what they're feeling. So those are some that if they have a significant head injury, we want to be a little bit more diligent about having those children be evaluated earlier by a medical provider.
I would agree with what Dr. Halstead said about the younger students. I think a lot of that when we work with parents with very young children is just to really look at their normal routine for sleeping, eating, playing, and try to make some assessments on are they being as they typically were before, or are they more irritable, are they more sleepy, and trying to make some adjustments there. I also see a question here about is there a way to help teachers understand what is essential work versus non-essential work? That's a difficult question because when we give that question or we give that suggestion over to teachers, it really is up to each teacher to decide what is essential in their classroom. And we know that there are some teachers who will say everything is absolutely essential in my classroom. People will say often that AP or IB teachers will say that. And some teachers will say, no, this is not essential and I can remove this work. But my experience, it seems to matter whether the teacher knows or has known anyone with a concussion is what determines what they say is essential or not. I've had some very strict teachers, very high achieving or high level classes, AP classes, that were able to say this is not essential and I'll do everything I can help you through this. So I think it's really up to the student to talk with each teacher and see what they can do to work out a reasonable plan of homework and in-class work during that recovery.
I see another question on here about differences between boys and girls. Absolutely, there are differences between the two, as we see with a lot of things between boys and girls. Two things. One is oftentimes in sports that are similar, that participation. So soccer for girls and boys, we do see that there are higher rates of concussions in girls as opposed to boys. When we talk about similar sports, same thing for lacrosse and basketball. We don't know exactly why that difference exists. There have been some theories. One is that girls sometimes are a little bit more forthcoming about their symptoms sometimes than boys are. Another is that girls have weaker neck muscles, which may predispose them to have a concussion as opposed to a boy with a stronger neck muscle base. But we also see differences in recovery, too. So girls do tend to take a little bit longer than boys when we look at statistics, particularly in the middle school age group. We see that as well. Again, all sorts of theories as far as why that potentially happens. It doesn't necessarily mean that girls are affected by it more. It just may mean that they have a little bit longer recovery period. But again, not dramatically longer, so we're not seeing really significant durations extended in girls versus boys, or dramatically higher rates in girls' sports versus boys' sports. And there is also a question on prior to the 4-week point, when should you seek medical attention if symptoms have improved? Again, that's an individualized thing. My general feeling is if your kid has been struggling with symptoms of their concussion and aren't improving and it's been there for a week, or if they're really certainly having any significant struggles with school, that would be something to seek medical attention for, because there may be some things that we can do or some education we can do to make a strategy to help that person get better. Potentially some additional information we can provide for the schools to give them some assistance in helping kids out. And certainly if there's anything else that we can do from a rehabilitation standpoint. So one common thing that we see a lot with concussions are neck injuries, because neck muscles get strained with that, and oftentimes that is something that we want to address sooner rather than later. There's another question on here about what point do we urge a parent to get their child a CT for concussion. So again, I don't tend to urge a parent to get one. We have to remember that CAT scans are not benign, meaning of no harm. There is radiation there that goes to the head when you get a CAT scan. So that is up to the medical provider as far as determining that. There are very specific criteria and guidelines that are very well established in the pediatric age group that determines whether or not someone truly needs a CAT scan, because there would be more concerning things. Those things that I mentioned in that earlier slide about when should you go to the ER, those are things that make us be a little bit more alarmed or concerned. But like I mentioned, those do not always mean that those things are going to result in someone needing a CAT scan. That may just need a period of appropriate observation for a little while to see if some of those things improve and being observed by someone medically trained. And then that person may actually do fine. So we try and avoid getting CAT scans as much as we can, especially just to look, so to speak, or to rule out other things, because there are very specific things that oftentimes those kids will experience that require us to get a CAT scan. And if you go to a pediatric trained facility, urgent cares, and ERs that work with children a lot, they generally, for the most part, are going to be comfortable knowing those things and do those imaging tests appropriately. So don't feel that your child has been neglected because they may not have had a CT scan. We actually prefer, for most of the concussions that we see, especially from sports, that those generally aren't necessary.
I see there's a question here about a child having a concussion when he was 2 and he's now 9 years old. Could there be lingering problems from that concussion? I know that once a child has had a concussion, it's always in the back of a parent's mind of whether or not symptoms that come later, are they really related to the concussion or would they have happened anyways? And that's always a difficult question, difficult to answer this question, because we don't know for sure whether or not anything that comes down the road could have come from that concussion or not. So this is, it would be worth talking to your pediatrician or a concussion specialist about this, because it's unlikely, or we hope that it's not, that anything is still lingering from a concussion when your son was 2 years old. But sometimes there are some very subtle eye tracking issues, or some very subtle inner ear vestibular issues, or some balance issues, or some subtle emotional behavioral issues that can sometimes track back to that point. So it's well worth looking at. You would really need a really good specialist to work with you to be able to figure out if it really came from that or not. And at some point, whether it did or not, it's just good to make a plan to move forward to help this child with whatever lingering problems might still be something that could be rehabilitated down the road. So it's worth looking into. There's also a question about AAP materials published that are directed towards schools. I'd say the best article that I can think of is the one that was mentioned earlier, the clinical report from the American Academy of Pediatrics that was written by Dr. Halstead. It's Returning to Learning, and that was in 2013. And many of the things that we talked about today are in that report, and that is a great starting place for schools to begin to get their heads around the medical components of concussion and how that relates and translates into supports for schools.
And I know Karen is very modest about promoting her own material, but she also has some excellent material out there at Get Schooled on Concussions. Is it .org, Karen, or .com?
.com.
.com. And so it's Get Schooled on Concussions, and that's actually some excellent materials that is put in terms of schools. Obviously, at the AAP, a lot of what we do is geared towards educating medical professionals. We certainly do the other things too, but that particular document is geared a little bit more towards medical professionals managing concussions. And so Karen has a lot more of the information that is really directed towards the school level and is excellent. There's also another question on here as far as what does change in pupil size indicate? I've heard that differences in pupil size in each eye is a sign of a serious head injury. That's an interesting one for two things. One, if you don't know, 4% of the population have pupils that are different sizes. And so there are people who have that just as a baseline difference. Our biggest concern is when pupils don't respond to light when we shine light in them, especially if there are differences in sizes there. That is generally not something that we get as concerned about in someone who is walking and talking and very active. That is generally something that we see as a very late finding suggestive of a very serious injury in somebody. And so we can certainly look for that, and we do look for that. But generally someone who is alert and talking to us, if they have unequal sized pupils, and especially if they respond to us shining a light in them and getting constricted and smaller again, those are generally not as big of a concern.
I'm going to go way back up to the beginning. There was a question about should we wake a child with a concussion and not let them sleep? That's a very common question that we get. And it goes back to what Dr. Halstead was talking about earlier about when we are evaluating kids with a concussion early on, we're actually evaluating for more serious things such as brain bleeds and fractures and things like that. So the whole myth of you should never let your child sleep after a concussion is really more about what we're trying to figure out is if your child is falling asleep but cannot be roused or waken up, that's more of an indication of something other than a concussion. That's more of an indication of a bleed. And that's why in the beginning of a hit to the head and a child who hasn't been evaluated medically yet, we do suggest that you wake them up so that you're seeing if you can rouse them. But once a child has been evaluated and is found not to have a brain bleed, then allowing your child to sleep for a concussion is actually a good thing to do, and it helps them recover from their concussion. So we would suggest that any child be evaluated, at least by your pediatrician, if not in an emergency room in those circumstances that Dr. Halstead talked about, to rule out a bleed. And then after that, if it is a concussion, sleeping can be a very good thing for them.
There was another question on here about, let's see where I missed it here, as far as how many concussions are too many until someone should quit their sport. And that's a little bit of a loaded question, and the reason why I say that is that we kind of describe it as no magic number. There's not one specific number. There are a lot of myths out there that there's this magic number of 3 concussions and then you should be done with sports. That's absolutely not the case. There's not a published guideline that states that that is the absolute end of being able to participate in sporting events or any sports for that matter. Obviously, there are variations in what happens with that person, and we really have to take an individualized approach. I've had patients that have had 1 concussion, and because of the effects that it had on them or the duration of time it took them to get better, we decided collectively as a medical professional and family that we were going to not have that person go back to contact sports. But I've had people who have had many more than that we have still allowed to participate in sports. So that's really an individualized decision and recommendation, and so there's not a magic number that we use. And there was another question about should my child take supplements to help treat a concussion. Interestingly, there is not any research out there that's been done in humans that shows a great effect of supplements as far as helping assist recovery in concussion. There are some studies that have been done in rat models looking at where they artificially hit a rat in the head with a mallet, and they may have given them a supplement before or after they have had their head injury, and they see how they perform, as an example, navigating through a maze. And there have been some studies that suggest that taking omega-3s either before or after that has helped the rat navigate the maze. But I would argue that we don't necessarily know that that is going to be necessarily translate into humans. And so I'm a little skeptical about that one as far as just saying that, blanket everybody should take omega-3s as an example, because that's the one that's used most commonly, unless your child's a rat trying to navigate through a maze, and then we may know that you may do a little bit better. So we just don't have the research yet to show that that really makes a difference one way or the other. I think if there was any other questions.
We pretty much have covered almost all of the questions. The only one that I see left is a question about if a trainer is not following the protocol, and how can a parent present this information in a meaningful way to not undermine the trainer's expertise. And I think the first thing you're doing by even gathering this information and becoming experts yourself is great. The more a parent understands, the better. And then I would just very gently work with the trainer and the school on new information, such as what Dr. Halstead presented today about exercise. And there's a lot of good information out there, good articles. Just trying to keep supporting the school and the trainer to be digesting all of that new information out there so that they can be applying it appropriately. And of course, if you feel that you're not getting anywhere there, then simply keep talking to the people at the school that would help the trainer to understand this. But oftentimes, that interpretation of the steps that Dr. Halstead talked about, the trainer might be doing many of the same things. It's just that they're calling it something differently. So it's sometimes just a bit of a translation in the language. So just keep working together, knowing that you're working on the concepts of a safe return to play. And I think that would probably help them to have more information in their expertise as well.
And I would echo that. I think most athletic trainers are out there to ensure the safety of your child, not to put them at risk. And so I think the vast majority of athletic trainers out there are doing a very good job as far as evaluating and assessing concussions, and also doing the appropriate steps as far as return to play. But obviously, if you do have concerns about how that's happening, another way that you may be able to approach that is speaking with, I think, talking to the athletic trainer first as far as what your concern may be, because there may be some miscommunication. We know how, talking with teenagers back and forth, that we don't always get the full message both ways of what's happening. And so that sometimes may be the miscommunication there. But if that's not to your satisfaction, then there's always an athletic director for a school that you can approach that to as another step. I did see the question as far as the son with schizencephaly. I am not aware of anything that puts them more vulnerable to a concussion, so that I am not aware of any literature that says that, but I'm certainly not an expert when we talk about schizencephaly and risk for head injury down the road. There is a question here on coaching middle school soccer, and this is a question we get a lot. Is heading the ball discouraged due to concussion? And have I heard of headbands? And yes, I absolutely have heard of headbands. Let's talk about both of those things. So first of all, heading, U.S. Soccer actually made recommendations that kids should not be heading the ball below the age of 10. The reason why that is because it's just a simple motor skill development problem. And so when we're trying to head a ball, having adequate control of neck muscles to do that is just not that great at that age. And so we don't want to try and have them do a skill that their body is not really motor skills development-wise able to do yet. And so that would set them up for more injury. We don't necessarily discourage heading due to the risk of concussion. We want to do proper heading. We tend to see most concussions that occur from the active heading not because of heading the ball, but because oftentimes two players are going up at the same time to head the ball and they don't see each other and they collide heads instead. Or someone is having the ball kicked at them and then they accidentally, technically, head the ball because they weren't prepared to actually head it properly. But if someone is heading the ball properly, we have much less concern about that person getting a concussion from those types of events. Doesn't mean that they can't happen, but certainly it's a less likely event. And then as far as headbands go, I am not a big supporter of headbands. That is not something that's a mystery, and I'll tell you why. I use the analogy as far as if the three most common sports to get concussions in boys are football, ice hockey, and lacrosse, and all three of those require a helmet to reduce concussions, yet they are still the three highest sports to get concussions in. A simple band of inflatable air around the head is certainly not going to reduce the likelihood of getting a concussion. And that's, again, it's just simple physics. If we put something as an external device around the head, the brain still moves in the skull when there is impact to the head. So you may lessen some of the external trauma, but unfortunately it's still going to cause the same type of force to the head. And there actually has been some research that shows when you put headbands on soccer athletes, compared to having them head a ball without a headband, they are much more aggressive and actually hit the ball harder with the headband on rather than without it. So again, we're adding a protective device, and even if there was a protective effect, we may negate that by putting that device on. And there's one final question, I think, here. If there isn't an athletic trainer at the school, who do you suggest manage return to play? That is going to be based on individual schools as far as who is the point person for that, similar to who may be involved at school, who is the point person that helps manage return to learn and return to school. So there may be an individual person who's involved with that. We don't obviously have athletic trainers at every school and at every level, certainly at levels below high school. So sometimes that is managed through the physician and directing how to do the return to play progression through the physician's advice.
I think we've answered all the questions. The rest of them have to do with copies of the slides, so I think we'll just kick that back over to the host so you can talk about any of the ways to get this information out. So thank you, everyone.
Thank you.
Thank you so much, Dr. Halstead and Dr. McAvoy. We really appreciate all the great information. We hope everybody enjoyed today's webinar. Please keep an eye out for a quick survey, which you will receive, and let us know what you thought about today's webinar. And once we have it ready, this webinar in its entirety will be made available on healthychildren.org. And as a registrant for the webinar, you will receive an announcement of when that's available. Thank you very much, everybody. Have a great day.